Hello, everyone. I hope you're enjoying this amazing symposia. My name is Eric Donenfeld, and I'm going to be talking about a subject today that I'm absolutely passionate about, and that is keratoconus game changer, what ODs need to know about cross-linking. I've been involved with keratoconus for a long time. As a corneal specialist, I've done tens of thousands of corneal transplants. I'm a professor at NYU, and I'm also the founder and surgical director of the Lions Eye Bank for Long Island. I work with Corneagen as well. Keratoconus is a extraordinary disease. It really robs people of their vision and quality of life. And we're going to be talking about something that I find very exciting, and that is we now have the ability to often stop or certainly slow down the progression of keratoconus. What we'll be talking about today is Photrexa viscous riboflavin from a company called Glaukos. This is the only FDA-approved cross-linking unit available in the United States. And here's some of the safety information. We'll get into this a little bit later on. I do consult with a variety of different companies in eye care, including Glaukos. So let's just start by doing an overview of keratoconus. What I like to do is maybe talk about keratoconus a little bit, and then we'll go on to talk about some of the treatment options, and then we'll get specifically into cross-linking at the very end. Keratoconus is a bilateral progressive corneal ectasia. About 95% of the time, 5% of the time it's unilateral, but it's probably not really unilateral. It starts in the teenage years. You can see it as early as 10 or 11 years of age. And most of these patients are in optometric offices. You're the people who are following these patients and diagnosing the disease. The original study, which is kind of in the literature right now, is that in the United States, it's 1 in 2,000 people, but the more modern literature suggests that maybe 1 in 400 people have keratoconus. And cross-linking was granted orphan status by the FDA in about 3 or 4 years ago. Keratoconus is the single most common reason why we perform corneal transplants in the United States, and over 6,000 were performed last year. Unfortunately, these corneal transplants are in some ways risky procedures. They work very well, but they almost always fail. Patients either get endothelial dysfunction, they need another transplant, or they get recurrent ectasia and keratoconus, with 73% of grafts failing in 20 years and 98% of them failing at 30 years. But even more heartbreaking than that is the fact that trauma steals the vision from many of our patients who have keratoconus, and it's estimated that about 1% of young males with keratoconus will actually lose their eye completely after trauma following a corneal transplant. So how can we prevent patients from going on to needing a corneal transplant? Well, the importance is really early diagnosis, and that's where we need to partner together to make the diagnosis. And very commonly, patients will come in and be easily missed unless you're actively looking for keratoconus. And since it's so common, it's something that you should be looking for on every single patient. It's important to diagnose the disease, educate the patients before vision is lost. And this is one of those times when you can really stop a disease from progressing early on and have a profound effect, probably more profound effect on a patient's life than anything you do in eye care. And that goes for ophthalmology and for optometry. We can probably have more of a profound effect by diagnosing keratoconus early than any other disease we manage. After cross-linking, patients are going to still need optometric care. They're still going to be monitored. They'll need to be seen on an annual basis. They'll still need soft or hard contact lenses very commonly. So what are the signs and symptoms of keratoconus? Well, many times these patients have a history of eye rubbing. It can be during the day. Many times they sleep on their eyes at night. It can be a familial genetic predisposition, and the literature says 1%, but it's probably higher than that. Things to look out for: patients who have blurred vision, especially blurred vision early on that's not correctable to a sharp 20/20. A 15-year-old should see 20/15. If they see 20/20 minus or 20/25, think about keratoconus. Look for refractive abnormalities, particularly distortion on keratometry, error message on the autorefractors, and increasing astigmatism. Anytime a patient who's younger has more than a diopter of astigmatism, I think you need to rule out keratoconus at an early age. Cilium findings are usually later findings. You will diagnose void striae, Fleischer's ring, Munson sign, and scarring, but that's an easy diagnosis to make, and that suggests that the keratoconus is at a later stage, stage 3 or 4 down the line. But something you can diagnose early on is dilated retinoscopy, and looking for scissoring on retinoscopy is a very easy and very accurate way of diagnosing keratoconus. I think the incidence of keratoconus is epidemic in the United States, and a lot of it has to do with the obesity problem. A lot of patients who are overweight sleep on their face, notably on their hands or their pillow pressed up against their eye, develop floppy eyelid syndrome. And this is something that I look for in every patient who comes in who has significant astigmatism or has keratoconus. Look for floppy eyelid syndrome. I think there's a very strong predisposition to patients who sleep on their eyes, and their lids will become floppy and their corneas will become floppy. And on top of that, 50% of these patients will also be diagnosed with sleep apnea. And this is a place where you can actually save someone's life by diagnosing sleep apnea. I was the first to make this association. We published this in ophthalmology a number of years ago, that keratoconus is associated with floppy eyelid syndrome. Again, so check the lids on your patients who come in. And as an aside, I would also mention to you that the patients who tend to progress the most rapidly with keratoconus are those patients who have floppy eyelid syndrome. So for me, that's a significant increased risk factor for more rapid progression of the disease. To diagnose keratoconus today, you need to have the right diagnostic equipment. A topographer is basically the gold standard. You can also have Schleimflug tomography, like the Pentacam, an anterior segment OCT, but a topographer is the gold standard, and it is very accurate. Probably the most accurate way of diagnosing keratoconus is looking for inferior steepening. And patients who do have keratoconus should really be diagnosed, and if necessary, consultations should be done. These patients will very commonly require post-op care, contact lens fitting. I'm very lucky on Long Island and in Connecticut where I am. I have some extraordinarily good contact lens fitters who help my patients, but these patients very commonly need specialty contact lens fitting. Here's the classic topography on a patient who has keratoconus. Look at noticing on the left side the inferior steepening. There can be posterior elevation changes as well, not so important. And focal thinning on the OCT will help diagnose it, but those are later findings. So for those of you who are interested in learning how to use a topographer, especially if you also are screening for keratoconus, but especially if you're doing refractive cataract surgery co-management or doing LASIK, we have some superb optometrists who we work with who diagnose keratoconus very, very easily in their office, but they have topographers. So what are the keys to a topographer? And I'll go through a few steps. I think this is just not only relevant to keratoconus, but again, relevant to cataract surgery and to LASIK or PRK as well. Kind of the gold standard has always been hemimeridional steepening. That means superiorly is flatter than inferiorly. An inferior superior ratio of 1.4 or less is probably normal. And that means that 3 separate data points taken above are 1.4 or less different than the readings taken below, again, below being steeper. When you get a inferior steepening that's really twice the superior steepening, or 1.9 keratometry different, that tells you probably have an abnormal cornea. The single most important sign of topography, however, is the non-orthogonal topography. We'll get into that a little bit later on. Ks of greater than 47, and pachymetry also plays a role if you have a tomographer as well. There are a lot of different technologies. I'll just jump right through this though, and bring us to the 3 different topography patterns that you should be looking for: normal, suspicious, and distinctly abnormal. When you look at topography, there are 3 normal patterns. It can be round, it can be oval, or it can have a symmetric bow tie. This is kind of an oval to round topography. very normal looking. Central, if you look at the color scales, the steepness here is about 44, very nicely in the range of a patient with a normal cornea. This cornea looks a little bit abnormal, but again, looking at the steepest part, it does get up to about 48, so it's a little steeper. But it's a bow tie topography, bow tie cylinder. It's symmetric. The superior steepness is equal to the inferior steepness, and single most importantly, it's a straight line. If you took a ruler and you put it through this topography, it would basically bifurcate the two areas of steepness. We'll get into that a little bit later on, but non-orthogonal is what you really want to look for. So when you start getting suspicious, this would be where you pick up early keratoconus, is looking at an asymmetric bow tie. That's asymmetric steepening, and again, a skewed axis is really important. So here's a patient with a inferior hemimeridional steepening. The inferior part of the cornea is steeper, but it's orthogonal, it's a straight line. This is a little bit abnormal, but not worrisome. And this cornea should be watched. If I saw this patient who is 15 years old, I'd follow this patient certainly every 6 months or so. If I saw this in a patient who's 40 years old, I would just chalk it up as a normal finding. When you start seeing this type of picture where the keratometry is non-orthogonal, it's not a straight line, that's when you start getting worried. And this is basically a precursor to actual keratoconus. This is called skewed radial axes. And then inferior steepening like this is also an abnormal topography. But now when you get into frank keratoconus, it's really much easier to make the diagnosis, except for one notable exception that I'll share with you in a few minutes. So looking at abnormal corneas, there are two basic abnormal corneas. There's keratoconus and there's pellucid marginal degeneration, which are all variants of the same disease. This is an active keratoconus. You can see the cornea color scale is about 55 inferiorly. It's inferior temporally displaced. The Myers are abnormal. Again, another inferior keratoconus. This is a little bit more abnormal, and it's not true keratoconus. If you look at the Ks, they're not really that steep here on your keratometry. The simulated Ks are 44 and 39, but notice that the lines are curved. This is a lazy 8 picture, and you've got kind of this curvature coming around. If you turn it sideways, it look a little bit like a crab claw. And this is pellucid marginal degeneration. And this is easily missed. And what's important about this is this will not be picked up by a lot of software that you have on topographers. So this will be read sometimes as normal. When you see that the lines are not straight and they kind of curve around and you have this little blue spot in the middle, think of pellucid marginal degeneration. Now, the most easily missed keratoconus diagnosis is this type. It's a bow tie keratoconus, but what you see here is this is a nipple cone. It's dead straight on, and what you're seeing here is the inferior superior ratios are the same. There's really no difference. This is a truncated bow tie. The keratoconus is very steep centrally, but it doesn't extend to the periphery. And again, one of the clues here is that the Ks here are over 50 to help you make the diagnosis. This is probably the most simple way of making the diagnosis of keratoconus is when you have skewed radial axes. You see the Lazio bow tie. The bow tie doesn't go in a straight line. It curves to the side. And when you have that skewed deviation, this is keratoconus. This is really a no-no for doing LASIK or PRK. It makes it more difficult for doing toric intraocular lenses, and this is the earliest finding you'll see on many patients who have keratoconus. And if you diagnose this, you can stop them from progressing before they become much more significant. This patient could probably still see 20/25 with glasses, but if you leave it alone, it's going to certainly get a lot worse. Again, pellucid, you see that crab claw appearance. It wants to form a little circle there. You see the flat area in the middle, and you see that the keratometry axes are very different. One axis is 22, the other axis is steep as 116. When you see a marked differential in axes between patients' two eyes, that's worrisome as well. And again, the skewed radial axis is here. For those of you who have tomographers, you can look at pachymetry, and I think pachymetry is a very underutilized diagnosis for keratoconus. Here you see two eyes of a patient that look fairly normal. The patients are pretty high myope. The pachymetry is really pretty good. But when you look at the posterior slide, you see some posterior float issues here, but you also see the pachymetry is a little bit abnormal. You see the thinnest location is 499, which is a good way away from the center of the cornea. In a normal cornea, the thinnest part of the cornea should be dead central. If it's off axis, if it's not in the central area, if it's off by more than 0.8 millimeters, it's abnormal. This cornea, if you look to the right of that red circle, you see that the thinnest location is 1.9 millimeters decentered inferiorly in the y-axis. That decentration, to me, is a very hard sign of an abnormal cornea. So I look for this in any patient who comes in who's considering having LASIK, or if I'm trying to diagnose keratoconus. Also, beware of unilateral keratoconus. This is obvious keratoconus on the right slide, but how about the left? Is that a normal cornea? This is the patient's other eye, and this patient was diagnosed as having a normal left eye and an abnormal right eye. And you can see here the right eye is abnormal, but when you look at the pachymetry maps, you see that the cornea is thin, significantly decentered inferiorly in the left eye. It goes down to 414, 1.59 millimeters inferiorly. But when you look at the right eye, you see the same thing. The thinnest area of the cornea is dramatically decentered from the center of the cornea, 1.19 millimeters. And this would be an abnormal cornea in my book, and would be one that I'd be following very carefully for the progression of keratoconus. So for screening, corneal topography is really the gold standard. Software is getting better and better. I like to use pachymetry as well. And in the future, we'll have biomechanics that will help us as well. So we've talked about screening for keratoconus, and we've talked a little bit about diagnosing keratoconus. Let's talk about its prevalence right now. And that is, how common is it? And again, I said that the United States, based on a paper done in 1986, it's always assumed it's about 1 in 2,000, but you can see around the world, these numbers are markedly different. In some countries, it's suggested maybe 1 in 50. And the incidence of keratoconus is increasing dramatically. It's estimated that in the United States, there are at least 1 million patients who have keratoconus in the United States. And I think that's an underdiagnosis of prevalence based on the epidemic of keratoconus that's associated with eye rubbing and with obesity here in the States. The real shame is, despite the advances in diagnostic tools, keratoconus is often diagnosed at a relatively late stage. And this is really sad. I've been doing cross-linking for 13 years. I was one of the leads of the FDA trial here in the United States for cross-linking. We started doing this, I think in 2007, I believe. And I figured by now that the word would be out there to send patients in for cross-linking. That's been approved by the FDA for a number of years now. But I'm still seeing patients walking in who are 17 and 18 years old, who have keratometries of 60, who've been followed by an optometrist for a year or two, and their keratoconus has not been arrested with cross-linking. I think that's just a shame that we could have prevented this disease from progressing at an earlier stage by diagnosing the disease. The patient would still stay in the hands of my optometric colleagues and would still have excellent care, but they'd have a much easier life than the life of a patient with keratoconus. And it's suggested in recent paper this year that 70% of patients have reached stage 2 on the Amsler-Krumite scale by the time of diagnosis. We want to diagnose as early as possible. Certainly, we're seeing patients coming in even later than that sometimes. It's also important to remember that keratoconus may progress very quickly. I'm always a little bit amazed by some family members who I'll diagnose the keratoconus in January, and they'll say, well, I'll do the cross-linking over the summer vacation 6 months later. And we've all seen patients progress very quickly. It's suggested that 80% of patients are slow progressors and 20% of patients are rapid progressors. The younger patients tend to be the rapid progressors, certainly the ones who rub their eyes as well. And there can be, again, very rapid progression of these diseases over the course of time. Here's a patient who came to see me who had presumed unilateral keratoconus. And you can see on the left screen here, you see active keratoconus. This patient um, had already lost a significant amount of vision. We cross-linked the left eye, and I told him to come back and see me again to follow the right eye every 6 months. And the patient came back a couple of years later. And look at the right eye in this picture. I'm sorry, look at the right screen in this picture, which is the left eye. And you can see a normal looking topography. And here's that patient actually 4 years later showing dramatic progression of keratoconus when the patient came back in. We could have stopped that progression by following that patient earlier on, but the patient did not come in. So I'm very, very quick to do cross-linking on the second eye of a patient who has keratoconus, knowing that progression is extraordinarily common in these patients. Early intervention with cross-linking really increases quality of life outcomes, and there are a number of papers that show that. A lot of patients with advanced keratoconus can see with contact lenses, and I want to say a major advance in keratoconus management has been scleral contact lenses. They are amazing for my patients who come in with keratoconus, but a lot of patients can't wear scleral lenses or hard contact lenses for that matter all day long. They can wear them 5, 6, 7 hours a day, and the rest of the day, they're basically visual cripples who are really restricted in their activities. They can't drive, they have difficulty watching TV. They may have pain and discomfort with these contact lenses. And keratoconus has a profound effect upon quality of life. Keeping patients in the earlier stages of keratoconus really contributes to quality of life, reduces stress, anxiety about progression of the disease, and also reduces the risk of a patient going on to need a corneal transplant. So in the past, certainly when I started training, the opticals for treating keratoconus were spectacles, toric contact lenses, gas permeable lenses, scleral lenses, and penetrating keratoplasty. By the way, there's a picture on the left of an old time, this is a Castroviejo corneal transplant, which is a square corneal transplant. He did them originally before they became round. These were probably done in the 1940s, the picture on the left. Now we've expanded our options. We have topographic laser ablations, and I've been doing a lot of that, a lot of work on that actually as well. Intracorneal rings or intacs. We have corneal crosslinking, which we'll talk specifically about. We have femtosecond assisted PK, and we have DALC, deep anterior lamellar keratoplasty. DALC has really been a significant improvement in the surgical management of keratoconus. You leave the patient's endothelium alone. You remove the bulk of the cornea, leaving a bed of this little decimus membrane, a little bit of stroma, and then you put the new cornea into place. And the nice thing about DALC is that you keep the patient's endothelium, and you also don't have a full thickness and wound, so that there's less risk of trauma in these patients. PKs certainly have a long track record, but there's a lot more endothelial rejection, trauma, open sky surgery, whereas DALC is a much more difficult surgical procedure, but limits the risk of surgical and long-term complications. So DALC has certainly been a game changer for those patients who need corneal transplantation. But my goal to talk today is to tell you why we shouldn't be doing corneal transplants anymore for keratoconus. There's just no reason for these patients to progress to that. And I said it before, and I'll say it again, I think among the most significant advances in eye care in my career has been the advent of cross-linking. This has been a game changer in managing patients with keratoconus, and it's a way of stopping or reducing the progression of the disease. It was first studied by Theo Seiler in 1994. It was published here in 1998. So this has been around for 20 to 22 years. And interestingly, by the way, it didn't come to ophthalmology first. Seiler took this information from dentistry, and in dentistry, they use UV light for cross-linking teeth to keep the enamel intact. So it was in dentistry before it came to ophthalmology. And cross-linking, as you all know, combines two very common entities. It combines vitamin B2 or riboflavin, a naturally occurring photosensitizer found in all human cells, and it has ultraviolet light or sunlight, essentially. It combines both of these very simple entities. And the protocol, starting when I did the FDA trials in 2007, has really been pretty much the same as it is today. It's epithelial debridement, riboflavin 0.1% applied for 30 minutes, a UV light of 365 nanometers with a fluence of 3 milliwatts per centimeter squared applied for 30 minutes. And there's still some problems with this, delayed healing and occasional infectious keratitis, but overwhelmingly, it's a very effective treatment. What I look for as a clinician when I'm doing cross-linking is I want to look at the patient's corneal stroma. I want to see that the riboflavin has penetrated through the cornea, and the cornea has a nice, deep, yellowish green appearance, and I look for flare in the anterior chamber showing that the riboflavin has actually penetrated through. And the FDA-approved cross-linking procedure we call iLink, and this is using the Glaukos cross-linking UV device with Photrexa. And here you see the device, and here is how the light is applied to the patient's cornea. The treatment, again, takes about 30 minutes per eye. In some of the earlier studies that we did, patients actually do get some improvement in vision. And I think it's important to have a conversation with patients. Everyone asks me about cross-linking. We've done several thousand cases now. What can I expect? And I tell patients not to expect an improvement in vision. Just don't. If you do get an improvement in vision, that'd be great. The average best corrected visual acuity improvement is about 1.26 lines. So the vision does get better if you look at the FDA trials, but it's over a slow period of time. There's a 1.1 diopter reduction in myopia, and the cornea becomes about 2 diopters flatter. My experience has been that the thinner and the steeper the cornea, the more significant the flattening occurs. And I have seen flattening of 5 to 7 diopters in some very thin corneas, very steep corneas. But one of the things to be aware of is that this is the expectation at 1 year. And in general, for the first 3 months, the patient will note a small worsening of their vision after cross-linking because the epithelium has been removed, has masked the steepness of the cornea, and the epithelium has to rehypertrophy to smooth out the cornea. So very commonly, patients will say the vision's a little worse for 3 months. From 3 to 6 months, it gets better. And between 6 months and a year, there's usually about a 1 to 2 line improvement in visual acuity. And that's important for some patients. About 80% of patients will notice an improvement. And here you see a difference map. This is the left eye. On the left side, that is before treatment. The right side, you see the same exact patient 3 months after treatment. And here you can see the difference map inferiorly showing a net flattening of the cornea that's occurred of 1.4 diopters over that period of 3 months. So this is the FDA-approved corneal cross-linking, iLink. It's approved for progressive keratoconus and corneal ectasia following refractive surgery. Notice it's approved for progressive disease. The clinical trial did not include pregnant women, patients under 14 or over 65. The procedure was done with a KXL system with Photrexa, which is a viscous riboflavin with 20% dextran, or a hypotonic Photrexa for thinner corneas. The FDA-approved treatment involves removing the epithelium for 9 millimeters, applying the Photrexa drops every 2 minutes for 30 minutes, then going to the slit lamp and checking the patient to make sure that they have good absorption with a yellowish-green stroma and flare in the anterior chamber. If the cornea is less than 400 microns, Then we add hypotonic riboflavin to swell the cornea, and we check and we repeat until the cornea has reached a thickness of 400 microns. And then we apply the UV light for 30 minutes, using again the same 3 milliwatts per centimeter squared for 30 minutes, and continue applying the riboflavin through the course of the procedure. Important to establish that cross-linking is not refractive surgery. We're not necessarily going to improve the vision, although we might. It's a medical procedure indicated to treat a disease. It's not going to reduce their dependence on glasses or contact lenses. Contact lenses and spectacles are still required, and they need to be followed in your offices for continued monitoring. It's estimated that 1 in 100 patients with keratoconus after cross-linking will continue to progress. Most commonly, in my experience, these patients who progress are patients who are eye rubbers, the floppy eyelid syndromes, the patients with eczema or atopic dermatitis who rub their eyes constantly. Patient with trisomy 13 will do exactly the same thing. The goal of cross-linking is to stiffen the cornea to prevent progression of the disease. And again, as I said, usually these patients will have steepening of the corneas at 1 month and then flattening when you follow them up at 1 year. So if you're in an area where you want to do cross-linking post-op management, it's very similar to what you do currently for PRK. And that is, just like with PRK, you put a bandaged contact lens on the eye. Before I do that, when I'm doing the procedure, I'll put a little antibiotic on the eye first. And then you want to use the normal treatment that you would do for a PRK. I use a topical antibiotic. I like to use a fluoroquinolone, ofloxacin, moxifloxacin are very good. I use a topical steroid. You don't have to use a strong steroid. You don't need something like Durezol or prednisolone acetate. You can use a softer steroid, but I use prednisolone acetate. I use loteprednol, are all very good drops to use. I use a topical NSAID, and one of the little pearls is pre-treat the patient with NSAIDs. I like to put an NSAID into the eye before I do surgery, and that basically reduces the prostaglandin load. There is a relatively new nonsteroidal called Bromsite, which has bromfenac in a vehicle that adheres to the ocular surface. And I find that particularly good at reducing pain postoperatively for both PRK and cross-linking. So I'll give the patient the Bromsite when they come into the office, and then postoperatively, they get the same Bromsite postoperatively twice a day for 2 or 3 days. But any nonsteroidal postoperatively is good. You can use Nepafenac, or you can use bromfenac as well, or ketorolac. Lubricating drops, and I always send them home with a opioid. I find Advil or Tylenol just are not enough for most patients. So I do send them home with a prescription. That'll save you a call at 3 in the morning from a patient who's very unhappy after their surgery. And I usually use Vicodin, but it's up to the doctor on what they want to use. Typically on day 1, the patient is seen, reinforced they shouldn't be rubbing their eyes. I have them wear a shield at night, no eye rubbing, frequent lubricants, and topical antibiotic steroid. I don't continue the NSAID for more than 3 days because NSAIDs for more than 3 days will delay epithelial healing. And then I have the patient back usually when I think the epithelium is going to be healed in, which is usually about day 4 or day 5. So I'll see them back on day 4 or 5. And at that point, I remove the contact lens. I'll use this topical antibiotic for a day or 2 afterwards, and then stop that. I usually continue the steroid for about a month. I usually taper it down 1 drop a week. So I'll use a loteprednol 4 times a day for the first week, 3 times for the second week, twice for the third week, and then once a day for the 4th week, and then stop it. At month 1, I do a topography assessment. It's not worth really refracting them at that time because the vision will be actively changing. You don't really want to give them new glasses, but you can put them back into a contact lens at that point, and then follow them at 3 months, 6 months, and a year to assess their topography, vision assessment, and make sure they're not progressing. I love to see them at a year and show them their topography preoperatively versus their topography 1 year later, showing how the keratometry has flattened over that course of time. Adverse events do occur. The most serious one being infectious keratitis, which you have anytime you remove the epithelium, similar to a PRK. The patients can progress, but again, for progressive keratoconus or for cornealtasia, in the FDA trials, there are patients who get haze, punctate keratitis. Certainly eye pain is common, reduced visual acuity, but most of the problems occur in the first week, and then after that, they're mild. But the most important thing to remember is that you need to promote epithelial healing. The enemy of cross-linking, and for PRK for that matter, is a persistent epithelial defect. And when I see a persistent epithelial defect, I get worried about it very much. We went through this a little bit, but I think it's really important to also mention that this is an epithelial healing that's taking place here. And you really want to support meibomian gland function and treat dry eye preoperatively to get the best possible healing. If the epithelial defect has not healed by 5 days, I consider this a subacute refractive emergency, and a persistent epithelial defect may lead to scarring. So I'll consider at 5 days, if it's not getting better, an amniotic membrane. I put them on oral doxycycline, oxervate for very severe cases. There's a new product called Regenerize that I like very much. Regenerize has a lot of growth factors and cytokines that promote healing. Serum tears are good, and I evaluate the patient again to make sure that I didn't miss floppy eyelid syndrome. It's the single most common reason why patients have epithelial healing problems is that they're sleeping and rubbing their eyes while they're sleeping. So have the patient sleep with a shield at night. And again, this is a type of a picture of an epithelial defect at 5 days I'd be worried about. I'd probably put an amniotic membrane on this patient, followed by a bandaged contact lens. And by the way, when you put a contact lens on these patients, remember these are keratoconic eyes. You want to use a bandaged contact lens that's on the steeper side so that it stays in place. Just this week, we published this paper in the Journal of Medical Economics. My co-authors, Dr. Lindstrom, Bertel, and I published this evaluation of how iLink reduces the risk of PK and how this is cost effective, not only to the patient, but to society as well. We performed a analysis of 4,000 eyes of 2,000 patients. We used the same criteria that were found in the FDA trials, where the mean age was 31. And we show that in slow progressors, you reduce the risk of corneal transplant from 8.7% to 0.3%. And in fast progressors, you reduce the risk from 92% of patients who are fast progressors down to 2.5%. And that there were an average of 28 fewer years in patients who have been cross-linked who have advanced keratoconus. The reason for the study was there have been 100 studies that have shown that keratoconus is effectively treated with cross-linking. But is this cost effective? Is the cost of the procedure a cost-effective treatment? And there are two aspects to cost-effective. One is there value to the patient over the course of their lifetime? And the second is there a direct cost savings in medical treatment? So in cost effectiveness, we compared the cost effectiveness of cross-linking, looking at how it affects workday occurrence, realizing that patients who have keratoconus are less efficient at work, they can't work as much and they have to take more days off, depending upon the severity of the disease, because they have trouble with their contact lenses. And we also looked at the cost savings. What is the cost of a patient going on to a corneal transplant? What is the risk of having to have scleral contact lenses versus a soft contact lens? And what we found was that the direct medical cost, the cost of a corneal transplant, which is about 20% of these patients, is a significant saving of $40,000 for patients who aren't cross-linked, have medical costs of $40,000, and it's $8,600 if you do have cross-linking. So that insurance companies and the government need to realize that cross-linking saves them money over the long term, and that over the course of a lifetime, there's a savings of about $43,000. If you look at the cost effectiveness saving of productivity, There's a national savings of about $150 million a year of cross-linking these patients. If you use a conservative estimate, if you use a more realistic estimate, it's almost $750 million a year are saved if you cross-link patients early. And of course, in the FDA trials, the mean age of the patient was 31, but in our clinical experience, we all know that most of the patients who come in with keratoconus come in with a disease in their teens. So the earlier you treat the disease, the more cost-effective the disease becomes. Let's talk just a little bit about insurance updates, because this was a real problem for me early on, and there were some problems with it, but Glaukos has done an extraordinary job of making this available. It's available on 6 national health plans, 62 regional plans, and about 96% of commercial lives are covered for cross-linking now in the United States. If you're not certain if they're covered, Glaukos will help you with this information. Glaukos does a great job of providing insurance information. You need to talk to patients about this as well. You need to document that the procedure is needed. And the single most significant problem that I have as a clinician in patients who I want to cross-link is that even if they come with keratoconus, I've got to document progression. And I can't do that because I've only seen them for the first time. So I really rely upon my optometric colleagues to show that there's been worsening of the disease. Their astigmatism has gotten worse, their myopia has gotten worse, their keratometry has gotten worse, and even best, their topography has gotten worse. Then I can go to the insurance carrier and make certain that I can get the procedure covered for the patient. Documentation is really key. Glaukos has launched, actually I think they're launching this coming week, iPath 360, which provides strategic marketing access for all Glaukos procedures, including the cross-linking procedure, and will help clinicians make certain that their patients are covered for the procedure. If they're not covered, they'll help them there as well. And this brings me to the final part about insurance company. Unfortunately, a lot of patients on Medicaid, who are the patients who need cross-linking the most. These are usually inner city, indigent patients who can't afford the cost of a cross-linking. And I'm really proud to partner with a company like Glaukos, who's gone out of their way to make sure that no patient is ever left behind. And 7% of the cases done nationally in the United States for cross-linking are done for free because Glaukos provides free medication and cross-linking to these patients when insurance is not available, once they've been vetted to really need the procedure done. And I think that's a real positive for Glaukos, and I'm, again, delighted to work with this company. I do FDA-approved on-label cross-linking using the KXL system with Photrexa. What I don't do is to use unapproved cross-linking for patients using older devices that are not approved by the FDA. I think a key for optometry, optometry who is the gatekeeper for keratoconus, if you want to optimize your practice and get to the next level of keratoconus care, Glaukos and Topcon have partnered to give access to all of you who don't have it, advanced topography. And this is a great topography unit, and Glaukos and Topcon are making it easily available. It says here $8,990 with a 2-year warranty for a world-class topographer, which will serve you extremely well for diagnosing keratoconus. You can bill for this as well in your offices, and it's very helpful for diagnosing other pathology, including dry eye, LASIK evaluations, refractive cataract surgery as well, and for following patients. We have our patients come in twice a year to have these done, and that is a reimbursable event to have this covered. We have a registry at Glaukos that you can participate in to look at the incidence of keratoconus. And I'll just sum up something, again, that I'm passionate about, in that I've been privileged as an ophthalmologist to be involved in a lot of new technologies. I was one of the first 5 people in the world to do excimer laser and LASIK. I've been involved in refractive cataract surgery, multifocal IOLs, a lot of advances in cornea and infectious disease, a lot of drug deliveries. But the thing I'm most proud of, I believe, is my involvement in the FDA trials with cross-linking. 80 years ago, which is not that long ago, polio crippled an entire generation. Millions of young people were crippled by polio. And then Jonas Salk came around, and the polio vaccine has essentially eradicated polio. It just doesn't exist any longer. Today, keratoconus visually cripples millions of young people. Every year, I see 1 or 2 patients who come in with trauma after a corneal transplant who don't have less vision, they have no vision. They go blind in their eyes following trauma. They can have flat anterior chambers. They can have hemorrhages. So that these visual cripples don't have to take place anymore. We don't have a vaccine for keratoconus, but we do have cross-linking, which can halt or slow the progression of the disease. And I think that this has been one of the most significant advances in optometry and in ophthalmology. And I hope all of you take advantage of this going forward. In conclusion, patients with progressive keratoconus should be educated regarding the risks and benefits of cross-linking. Optometrists play a critical part in ensuring early diagnosis, monitoring, and continuing care. And the financial hurdles that are preventing some of these patients are thankfully being taken care of by Glaukos, which is really providing medication for free for these patients, and an increased number of patients who do have insurance are now obviously covered. The safety information I showed you before. And on behalf of my grandchildren, I want to thank all of you for being with us here today. And at this point, I'll turn the microphone over to my friend and colleague, Damon Durker, who will help us with the Q&A here today as well. Damon is a optometrist who works in Indiana. Damon, welcome aboard.
Yeah, thanks, Dr. Donenfeld. That was fantastic information. And this is something that we actually implemented in our practice over the shutdown. You know, we looked at things in March, April, May, where everything was limited to urgent and emergent care. And there were some things on our to-do or wish list, and cross-linking was one of them. So we started doing this here in June, and the response has been tremendous in our community. And I'm really excited that our practice is now part of this. So thanks again for all that information. We do have some questions from our attendees, Dr. Donenfeld. Would you consider a patient that has a bow tie topography, but relatively steep, say that the K is 49, you know, regular topography, K of 49, is that patient a keratoconic, or do they have a keratoconus suspect diagnosis?
I would call that a suspect, Damon. That patient should be followed closely. And again, you need to take into account other risk factors. What is the pachymetry on that patient? I want to know, is the cornea thin or is it thick? If it's thick, I worry about it less. Is the patient younger? If that patient was 18 years of age, I'd be of significant concern. If they were 40, I would not be. And then I also want to check them for floppy eyelid syndrome. I want to check them that they have that risk factor, that they may be rubbing their eye and causing this to progress. But it's a multifaceted diagnosis, but a patient like you just described, I would follow.
Great. So if you're an optometrist in a primary care setting and you see somebody that you're pretty certain has keratoconus, what should that conversation look like in 2020 if you've documented topographic changes and you're pretty certain this patient has a progressive disorder? What would that conversation in your chair look like, Dr. Donenfeld?
Well, that patient should have a conversation that they have a disorder of their cornea, and I explain what the cornea is to the patient. I call it the watch crystal of the eye, and that their cornea looks steep and irregular, and that in the past there was nothing to be done about it, but today we do have a treatment. I think the patient should have a evaluation by a doctor who does the cross-linking procedure to see if they are eligible for treatment. I would warn the patient that this is a progressive disease. You also want to know the family history. You know, are there other family members who have the disease? And that would be important. And this hasn't really come up yet, but I think since cross-linking is now FDA approved and is becoming commonplace, I am concerned that there are going to be a number of patients who are going to be coming in who will not be diagnosed who will have progressive disease, where they are going to be putting the doctors at risk of litigation for failure to diagnose a preventable disease. So I think it's something that we need to get in front of to make certain that these patients don't slip through the cracks and we can prevent them from getting worse for their own patient's own benefit and for the safety of your practice as well.
Yeah, I think that's a really critical point is now that we have, I mean, I think about my training 20 years ago in optometry school, and all of the things that you described early on in the presentation were all late signs of the disease. Now we have so much better technology to be able to detect early disease, early progression. And now that we have FDA approved treatment, that does put some liability on us as optometrists to be able to make sure that we identify these patients. And if for some reason we don't have this technology in our practice, to get them to a colleague that has topography, that has familiarity with managing this disease. But I think all of us have to be screening these patients, and it's really underdiagnosed, as you said, with maybe as many as out of every 400 patients that we may see in our chair having keratoconus.
You know, Damien, you may make a very good point there. And I'm going to say something that may be a little controversial right here, but that's never stopped me before. And that is that when children go to school, they have their vision screened. And those who are screened, who fail the screening test, are sent to an optometrist generally for visual evaluation. With an incidence of 1 in 400, doesn't it make sense when you're in high school maybe that we should have a screening process in all high schools, that all high school students should have topography performed? It's a simple thing that can be done in a matter of minutes for each patient, and they should be screened. Those who are abnormal should be sent to an eye care professional to be evaluated. I could see with the incidence of keratoconus becoming so common and crosslinking being so effective, that why shouldn't every single patient who maybe gets to the age of 16 have a topography performed once in their lifetime to see if they are at risk of developing keratoconus?
I don't really find that terribly controversial because we have the technology to do it. And if you can find something that with the topography that's cost effective, the test takes less than a minute to do, and you can screen patients or, you know, teenagers that have a risk for, you know, severe vision problems over their lifetime, why wouldn't you at least consider that? So I think that's totally reasonable. We have another question about, you know, how long does the documentation need to go back to have eligible insurance coverage? How much of a track record do you need to document that this is medically indicated?
Well, they want its progression of the disease, and it's defined a little differently by different people, but generally it's a diopter or worse of myopia, or a diopter more of cylinder, or progression of keratometry on topography. But it has to be a visually significant. But most of these patients don't really come in with serial topographies. They just come in with their glasses. But if you show their cylinder's gone from 1 to 2 diopters, that's progression of disease.
And would that be the most common thing that you see, is simply a spec RX change?
Yes, that's what I see now. Except for some of my colleagues, the optometrists who I work with, who have topographers, and they have actual documented progression of the cone and that's the best evidence of all. And I think that this is something that you would know better than me, Damon, but you know, how many optometrists have topographers in their offices now?
It's a lot more than it was 5 or 10 years ago, but I would say that it's not yet reached what would be community standard of care, which would be the majority. I don't think we're there yet as a profession.
Yeah, it's something to consider. I mean, it's cost effective. You know, I think, you know, a topography will pay for itself with its use. There's a variety of ways to use it in the office, and you'll be doing a significant service to your patients as well.
And you've actually made a nice pitch for our session coming up in a couple hours, is generating practice revenue with corneal topography by Steve Turpin. So thank you for that, Dr. Donnenfeld.
There you go.
And then our last question is, you know, as we have our eyes on 2021, what advice do you give for ODs that want to get involved in cross-linking co-management? What are the next steps?
Well, you need to find someone in your community who does cross-linking. And actually, you don't need to find someone in your community. You need to find someone who does it, who's reasonable. Early on, I was one of the 3 or 4 people in the country who were doing it. We had people coming in from all over the country. But it's best to find someone, within a reasonable geographic distance from you, and then speak to that doctor and talk to them about how you want to get involved with it, and demonstrate your interest. And I think if you really want to get involved in crosslinking, I think you need to have a topographer. So I think you need to make that financial investment as well. And then work with that doctor to make certain the patient get good care. And part of cross-linking co-management is you need to diagnose the keratoconus, you need to send the patient for the appropriate treatment, and then you need to either you or have someone you work with who can do the contact lens management post-operative as well, because these patients will almost always require specialty contact lenses as well.
This has been a fantastic session. Again, thank you so much, Dr. Donenfeld. I really enjoyed it. I've got 2 raffle codes for today, abrasion and keratoconus. Those are your 2 bonus raffle codes. Go ahead and get into the exhibit hall, into the Career Center. Be back here in 15 minutes for our session. I'll be having a conversation with Jonathan Smith on building a practice for the future. Again, thanks for joining us, and see you again in a few minutes.
Thanks, David.